Hello, everybody. Welcome to HeartBrief, another episode of some literature this week that I hope will upgrade your knowledge and help you in your practice and in your own health. I'm Joel Kahn, medical doctor, preventive cardiologist, triple board certified, Southeastern Michigan and Southeastern Florida offices. Well, let's get going and we'll go to the marvelous ability to share articles. And then I'm going to start with the big one, which is an article in Circulation Research, always considered a prominent place to publish. First author Daniel Gaudet, and this was just published this week for us to enjoy. New and emerging therapeutic targets for ApoB containing particle lowering. That's a title. Basically, the premise here is if we had to redo the language of cardiac prevention and cholesterol management, we might take out the word LDL cholesterol and always put in the word apolipoprotein B or ApoB. This is not an entirely new concept. I lectured 30 years ago with the famous Thomas Dayspring, MD from New Jersey, and he repeated over and over in a very long lecture, it's an ApoB world, boys and girls, and he wanted us to appreciate that this is a very simple lab test that reflected the entirety of atherogenic risk better than LDL cholesterol alone, because it turns out every atherogenic particle floating in the blood is wrapped with an ApoB around it. And I tell my patients to make it simple, think of a hot dog wrapped in a bacon. The bacon is the ApoB. If you just count how many bacon slices are in your blood, we can measure all atherogenic particles. And you can see here, hopefully, in figure one, since I'm sharing, that the central one, ApoB 100, is the one we talk about the most when we use the term ApoB, because it represents both LDL cholesterol concentration and, very importantly, lipoprotein little a concentration. And ApoB measurement represents both of those together. Now, in perhaps 75% of people, there's not much or any lipoprotein A in the blood. But for 25% of people where there's a lot of lipoprotein A is also wrapped like a hot dog and bacon with ApoB. You're going to measure ApoB, and it's going to represent the concentration of both LDL cholesterol and lipoprotein little a. If you look to the left, there's also ApoB 48, which is more related to less obscure problems involving chylomicron synthesis, chylomicron absorption, the lymphatic flow, and really more related to triglyceride abnormalities. And we're usually measuring ApoB 100. We don't often use that term, but we do. There are special medications available specifically for ApoB 48, but most of them are geared to the ApoB 100. And there's more and more coming out, as is identified here. The drugs ANGPTL3, 4, and 8 that are emerging, being studied, and are going to add to our overall armamentarium. Of course, anytime you're prescribing a statin, anytime you're prescribing ezetimibe, anytime you're prescribing a PCSK9 inhibitor, you are going to be lowering lipoprotein little a, you're going to be lowering ApoB, and we're going to develop new therapies, both for ApoB 48 and ApoB 100. Even LDL pheresis, if you see the picture here in figure 3, for people with multiple vascular events not being controlled with conventional therapies, with people with familial hyperlipidemia, heterozygous, or certainly homozygous, we may hook them up to a filter that captures the LDL in the filter and removes it in every 2 weeks, average interval. We're going to repeat this blood cleansing. So I encourage you that ApoB measurement is both in the new ACC/AHA guidelines that came out maybe 2 months ago, that the drug companies are gearing to find more and more ApoB reducing therapies. Of course, diet does it, fitness does it, some supplements, red yeast, rice, and niacin, Probably the two most potent can do it, but it's largely pharmacologic agents. I do want to add there was one misspeak out of my mouth that can happen. Statins do not lower lipoprotein little a, as etimib is neutral for lipoprotein little a, and the PCSK9 inhibitors decrease lipoprotein little a. So I just wanted to clear that up. ApoB World, just like I listened to from Dr. Dayspring quite a bit ago. Okay, so we are going to go on to a completely different article, one that I hope you will find interesting in the International Journal of Cancer. Here we go. And this was an analysis that'll sit well with some of you, might not in terms of your own habits, but meat intake and risk of gastric and esophageal adenocarcinoma in the EPIC study. This is a massive database. Is this a double-blind randomized prospective study? Oh, no, it is not. Just published, pages 1 through 12. But whether meat consumption increases the risk of gastric cancer and esophageal cancer or not remains unclear. So they had a database with 450,000 individuals, 14 years of follow-up. There are a little more than 1,000 cases of gastric and esophageal cancer identified in 14 years of follow-up. And what they were able to identify from nutritional histories was their overall meat intake and estimates of processed meat intake. And they found that a 30 gram per day increase in processed meat consumption was associated with a 9% increase in gastric cancer and a 13% increase in esophageal cancer. Additionally, a 20 gram per day increase in white meat intake, processed, sliced turkey from a package, was associated with a 12% increase in gastric cancer. So we have further data, if you remember and go back to 2015, the World Health Organization announced at that time that processed red meat was considered a carcinogen, a class 1 carcinogen. And now we have more data that 11 years later that suggests, although you might say 1,000 cases of these two cancers out of 450,000 people over 14 years, I'm going to enjoy my sandwich with ham, my sandwich with processed turkey, my sandwich with bologna or salami. But across a large population, this is apparently raising cancer risk. And I'd suggest you get out a nice hummus and a slice of tomato and lettuce and put it between those two pieces of whole grain bread or that wonderful whole grain wrap and just ditch the lunch meats. Plus, tell your patients to ditch the lunch meats, okay? So we're going to go to the last article here, if you don't mind, at HeartBrief. One more that is interesting and is also related to nutrition. And here we go. This is going to be in the American Journal of Clinical Nutrition. Consumption of organic compared with conventional fruits and vegetables in relation to cancer risk. The Nutrinet Santé cohort study. The Nutrinet Santé cohort study is a large and well-known prospective study, but it's an observational study with a nutritional database. And they knew in 31,179 participants, 75% female, how many servings of fruits and vegetables they ate in an average week, how many of them were organic, how many of them were conventional, and what the outcome was in terms of the risk of particularly breast cancer. And what they identified was that there was, by quintile, the higher the amount of organic fruits and vegetables consumed, the lower the risk of breast cancer, particularly in postmenopausal women. When running marginal structural models and testing for additional adjustments, findings remain significant for postmenopausal breast cancer. And the conclusion in the present work, substituting conventional fruit and vegetables with organic ones was associated with a reduced risk of postmenopausal cancer. The specific role of organic fruit and vegetables compared with conventional fruit and vegetables need further investigation, of course. So again, not a double-blind randomized study. We're simply not going to get one. Access to organic produce is an issue. Generally, the frozen fruit and vegetable section is a great place to start, both for cost and availability. I personally shop a lot for organic produce at, example, Costco. Their fruit organic section tends to be quite large, less so their vegetables. Certainly, if you have access to a Whole Food, I have no relationship to any of these companies, but Whole Food tends to have a lot of organic produce, and maybe you have a vendor in your area. Now, if you know a good farmer, a good CSA, and you have a relationship to ask about pesticide and herbicide use and genetically modified fruits and vegetables, go ahead and maybe you can just buy from a local farmer and come out in a good situation. But for the meantime, there's at least some incentive to select organic when possible. And I do agree with this and do follow it in my own home. So I want to thank you very much for three articles: ApoB, the new LDL cholesterol, and actually a better LDL cholesterol, and the other two nutrition articles that we talked about. We'll see you again next week for HeartBrief. I'm Joel Kahn, medical doctor, signing out.